Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And we are going to talk about ankle arthroscopy or ankle scopes, much the same as knee and hip and shoulder arthroscopy. Probably an underutilized technique.
Oh, very. I honestly think that we should be doing 10 times as much. It's just something that we see ankle problems, we see synovitis, we see these aches and pains, and I feel like we're doing conservative therapy, steroid shots, and all that, and we're worried about the next step, doing big surgery, but that medial ground, that middle ground, that ankle scope, super underutilized.
Yeah, I think we can find things that you're not going to see with MR and or magnetic resonance imaging MRIs, and those can lead you down a different path sometimes. Simply just flushing out the joint, which we'll talk about, it can be enough to really help a lot of folks.
Yeah, there's a couple of studies out that showed that simply just irrigating the joint out, real simple, no fancy, no going in, no chopping away, no cleaning up, just washing out that ankle joint has a 70% success rate.
Yeah.
It's so simple. I mean, honestly, you're washing out all those inflammatory markers and all the, everything that's causing those aches and pains, taking all that bad synovial fluid out of there and putting in nice, healthy joint fluid, and hopefully, presto changeo, brand new joint. So, ankle pain. We've talked about this previously. Today we're going to be talking about anterior ankle pain. The anterior synovitis, usually that impingement type of syndrome. Typically, patients will relate walking around and feeling a sharp pinch, and they got to shake it off, and then they'll be inflamed, and angry for a couple of days. They have that deep ankle pain, but nothing, seems to fix it, and they'll have those sharp pains every so often.
So you can see with your big picture in the middle, those little fingers of looks almost like kelp or seaweed.
Yeah, a little villi kind of pushing through there.
And those get pinched. They're full of nerve endings. They're full of blood vessels, and that's a source of pain, clearly. So when that stuff gets overgrown in the joint, it's usually a result of some sort of injury. A lot of times lateral ankle sprains, something as simple as that. And then maybe months or years later, it's built up enough that it starts causing problems. But in your upper left-hand picture, you can see it's kind of getting sucked in there. It's getting tucked between the tibia and the talus.
Yeah, this is the tibia right here. This is the talus, and it's literally getting pulled in. And this is after it's been cleaned out much. But you can tell. I tell patients this. Nice, healthy synovium will be like a nice rug, right? Nice and clean. It'll have that nice, flat, superficial surface. And then angry synovium, those villi are like a shag rug. So when you're walking, it's pinching those spots off, and then that's when they'll have that deep ankle pain. Walking all day, it's moving that joint fluid everywhere. And then that sharp pain whenever they bring that ankle just high enough, and it pinches that tissue off. And they'll notice it,
And then you've got cytokines, inflammatory cytokines, which are little chemical components of inflammation that are in the joint, just causing the synovial lining to get even more irritated. It's kind of a feedback loop.
Yeah. And
again, like you said, just flushing the joint out with saline is enough to calm a lot of these down. You flush the joint out with saline and shave away all that overgrown synovium, that can make a big difference.
Yeah, according to the AOFAS, simple cleaning up of the joint has a 90+ success rate.
That's awesome.
I mean,
and I think that's what we see with arthroscopy, and so I think we're big proponents.
So what is synovitis? What's happening? We talked about this, just real simple. The tibia and the talus. You're walking, sometimes you'll get a little spurring on the front, and that synovium will come through and pinch off, right? We're going to go in, we're going to clean that up. I mean, it's as straightforward as it gets. We don't really do too much diagnostic stuff aside from, steroid shots, x-rays, and whatnot. Most times you're not getting MRIs on these unless we're really concerned about like an osteochondral defect or, anything severe going on. But here, this is a good MRI of what it looks like. You see that inflammation, that white on the front, that's the fluid pocketing everything, and that synovium, that soft tissue, getting pinched off by those that anterior gutter on the front of that ankle.
And a lot of times you're also going to see joint mice, which are just little cartilaginous pieces that are floating around in the joint. They get ossified.
Yeah, the chondrocalcinosis. They literally are flecks of cartilage that have been shaved off, injured, or whatever, and they just kind of float through there. They calcify. They'll typically fall towards the gutters, but sometimes they'll stay in the front. Sometimes they'll attach to the tissue. Sometimes we'll see them in the back of the ankle, and there'll be points of impingement.
And they just grind away at things.
Yeah, honestly.
I mean, if you think about where that thing can end up, it could end up just grinding away more cartilage. It's
gravel in your joint.
Exactly.
Yeah.
The other thing we'll see is fibrous bands, which are little crisscrossing bands of scar tissue that sometimes will literally come across the talar dome, like one part of the talar dome, and start rubbing away cartilage.
Yeah.
They can snap. Some people feel them inside the joint. They're like, yeah, every time I do this certain maneuver, I get this pop.
One twist, I can feel it. Or whenever I'm walking on incline, I can feel that snap.
So you can get rid of all that stuff pretty easily with arthroscopy. So
portal placement. So this is pretty important. This is honestly probably the most important part of ankle arthroscopy. The rest of it, like I said, you can even wash that joint out and you're going to have great success. So your anterior medial portal, that is the most important. Typically what I'll do is I'll put my ankle through range of motion. I'll put my thumb on that medial gutter and I'll feel where the gutter and the front of the tibia and the talus kind of meet. About a centimeter down, half a centimeter down, I'll put a little mark because that's where I want to do my placement. You don't want to start high because then the dome of the talus, you're finding the opposite direction. You want to start just a little bit lower and then you'll come across. Also, I'm feeling for the medial side of the tibialis anterior tendon. That's that tendon that comes up on the front of the ankle, that one that bowstrings most of the time. So we're coming right to the medial edge of that. If you go more medial, you're going to end up, violating that great saphenous vein, and you don't want to, cause problems with that. And then after we do our portal, we place our scope all the way across. This is the way I typically do it. I'll bring my scope all the way across. I'll tent it, and you can see the light shining through it. And then I'll do a small stab incision that makes sure that I'm not going to catch any of those, the superficial peroneal nerve or the peroneus tertius tendon.
Right. So that's why that central portal isn't very useful and it's probably going to cause more trouble than it's worth.
Yeah, you're at risk of violating the tendon, one, obviously, but two, more importantly, the neurovascular structure. You're literally just a couple millimeters away from it.
Yeah, it's not worth it in my estimation.
Yeah. Yep. And then if you want to do lateral, if you want to do posterior ankle, I've done it a couple times. I've done it in training. I've done it here and there. Honestly, I prefer to do these open. Most of the time, we're doing posterior ankle for, those os trigonum syndromes or Shepherd's fractures. That's the small fracture off of this back talus lateral prominence. What ends up happening, you get that posterior impingement. It's that nutcracker syndrome when ballet dancers go on point and they get that little small stress fracture or fracture, and you're pinching that portion of bone off, and
you can have an outcropping that's irritating the flexor lucis.
Yeah, exactly. Yeah. So we'll go in. You can do it arthroscopically. I typically go medial and lateral. When I did this, I do these open now. But when I did this, I go medial lateral to the tendon, the Achilles tendon, and very straightforward. The hard part about that is you're working through these small incisions and you're dissecting these things out, where it'll take you maybe half an hour, 45 minutes to do this. If I did this open, 15, 20 minutes, honestly, in and out, lateral incision about 3 to 4 centimeters, and recovery is the same.
It's like trying to scope the great toe joint. Like, you can do it, but is it worth it? Does it make sense?
Yeah.
Probably not. It's the fiddle factor is pretty high.
So here's kind of what I was talking about. Small incision. I put my cannula and trocar in. Take the the trocar out. Put my scope in. Push it towards the lateral side. See that little pucker, yep. And then small incision, and put my shaver, burr, rasp, whatever you want to use. And then distractor. Some people are fans. Some people aren't. I'm a big fan of the distractor. Bless you.
Yeah.
I'm a big fan of the distractor. It helps out with surgery. I typically use a distractor like this. I think you use this style, right? The body style?
Well, simply with a Curlix roll. I've gone basics, man.
Yeah.
I never have to worry about a facility that I happen to be operating in that day not having what I need, because everybody's got Curlix.
That's happened to me. I literally had a case where they had everything, but they were missing the clamp point for that rod that you use to distract. Yep. So I'm like, all right. And I had to do the body tie. I used this band, and then I had them do Curlix around my waist, and just kind of to that.
It's called the skier's wrap. It's a pretty quick little technique, and they time you up into it, and you can just lean back and get your distraction that way.
You don't need a lot of pressure. They say 30 to 40 pounds. So honestly, you don't need that much.
Right.
I mean, just enough to move that ankle joint around and just distract it.
I hate to say this, but in residency, we had one of our ortho guys he liked to use femoral distractors, and that's literally drilling a hole into the tibia,
all the way
hole into the calcaneus, and then using a device that cranks them apart. You could get the ankle distracted significantly, but God knows what you were doing to the soft tissues.
There's a couple. I mean, that's
you could get all the way to the back of the ankle joint. I mean, it was beautiful, but I always worried, man, I wonder what we're doing to these nerves.
There's a couple of papers I was reading recently where distractors, when you do more than 30 to 40 pounds, I mean, that's when they say 30 pounds is pretty much where you want to stop, that you can get, if it's more than 30 pounds for more than an hour, there's a high incidence of neuropraxia
I believe it.
of the superficial peroneal nerve.
Yeah, it doesn't like traction.
That's your traction.
So don't do that.
Yeah.
Yeah.
So simple, distract it. Honestly, the biggest thing is you're using a straight scope, a hard metal rod, and you're working over a curved surface. The purpose of the distractor is to give you a little bit of wiggle room so you can see that front 1/3. And honestly, the most important thing is when you're in there, you're using your body to move that up and down. I mean, you're literally, you're using your body to move that up and down, or you're having your assistant, like, hey, plantar flex that ankle as much as you can for me, and I'll, get as much, whatever I can on the back of that talus. So here's one of Dr. D's scope videos. I'm going to jump ahead because I know that,
we did this one about 6 weeks ago. Patient's doing really well.
There we go.
Classic example of just anterior lateral chronic joint pain that didn't respond to conservative measures. The MRI showed there wasn't any osteochondral defect. There wasn't any major microfracture required for any of this. It was just synovitis from my estimation. I get in there and I'm like, yep, that's pretty much what's going on.
Yeah, so Dr. D is trying to get that cannula through. So you'll see, hopefully, that pucker out. And
poking through the obturator.
There we go.
So now we've got our portal in the, I'm sure that's the anterior lateral, right? Yeah.
Yep. So I don't know if you guys noticed this. Dr. D didn't start shaving up until he saw the shaver head facing towards him. When you see that shaver head, then you know you're safe. You see exactly what you're doing. We're not trying to go in there blindly, sweep across there and knock out everything. We're trying to slowly, in controlled manner, clean up that synovial tissue, all that fraying tissue. And the nice thing about these shavers are, the way this works is the scope, the camera and the light source are pushing fluid in, and you use gravity, use a pump. Gravity. Yeah, you'll put that 3,000 bag up top, nice and high, and you let that gravity just slowly push that fluid in just a little bit, that you're getting that pucker of that tissue pushing outwards. You don't need to really blow it up too much. And then the shaver is actually pulling fluid in. So it's pulling that fluid in, and Dr. D...
with all the debris.
Yeah, with the debris and all that whatnot. And you'll do a dance, right, about how you want to...
You can see right now. So if I've got too much suction, it pulls in the joint capsule around it, and I can't see. So you've got a dance between your inflow and your outflow. But once you get it set up, then you can see exactly what you need to see.
Yeah.
And what we're seeing right now is that the tibia and the talus, the cartilaginous surfaces, look really nice. So there's really nothing going on there.
So this is the talus right here. This is the tibia. Right. This is the fibula back here. You can't really see it too much. Let's jump ahead.
So we got some good pictures of that, and we did our joint survey.
So you made that pocket on that front of that anterior lateral portal, and now you're going to work laterally, I'm assuming? That's typically what I do. Go anterior and then work my way in a circle.
We're trying to take a little peek into the lateral gutter and just make sure we haven't left any fibrocartilaginous, osteocartilaginous fragments like joint mice. Cleaning out any fibrous tissue. You can sometimes use a grabber and pull out some stuff.
Yeah.
But that reciprocating shaver works great.
Yeah, that's pretty much what I'm using, like 80-90% of the procedure.
So I'm distracting right now using the Acrylex roll to really pull that joint apart a little bit.
He's peeking into the lateral gutter.
Yep.
I'm going to jump ahead because now we're just looking at stuff.
And then, at some point we're going to flip-flop the portals and come in, be able to see the medial gutter a little bit better. So I'm pretty happy with the way that looks. Now we're going to pull it out, flip-flop the portals.
So one thing, whenever you go into these portals, obviously now the fluid's gone and that blood will start trickling back in. Use epinephrine, I'm guessing?
Yeah, we're using Marcaine with epinephrine to limit the bleeding in the joint, because obviously a hemarthrosis is hard to see through. So
yeah. These, I don't know why. I don't know. If you remember the old James Bond films and whatnot, where he comes out and he's like, da-da-da, and he shoots you, and you see the blood kind of, and you tip away. That's what this reminds me of so much.
Yeah, absolutely.
So that epinephrine, what that's doing is it's vasoconstricting. It's causing that bleeding to be at minimum.
Right.
I typically use like a half saline, half Lido with epi. Use Marcaine with epi. I mean, it doesn't make a difference, honestly. The purpose being so you don't get too much bleeding through, and so makes your surgery a lot easier.
We're firing up the saline flow. Now you can see. So now you can see that there's some injected synovial lining. There's the little fibrils, these little tendrils of synovial lining that are problematic. So we're going to try to shave all that stuff out of there. And you've got an area of cartilage that's been kind of broken down, scuffed, and is frayed over here that you couldn't see from the other view. So that's one of the reasons, obviously, to flip flop, is you want to be able to see the entire.
You can see how that tissue can peek into that joint and just get pinched off and be super tender. So
we're going to try to just clean that whole gutter up. Now you can see, look, we've really cleaned that up nicely.
Yeah.
Taking down that frayed cartilage, just kind of cleaning that up a little bit. And none of this looked like it was, full thickness separation.
Yeah.
There's
no
reason
drilling
to
through.
Microfracture.
Yeah, so Dr. D is talking about if there's significant cartilage loss, sometimes it'll be shaved away and that joint mass will be kind of floating around, or it'll be still attached and you kind of get in there and you can see it flapping around, and we'll clean that up. After that, you'll go through and microdrill or microfracture. The goal being now that that bleeding will come through, you'll get fibrous cartilage build up there. I mean, you can use fancy paste and stem cells and all that fun stuff, but the baseline therapy is just drilling through so you can get some sort of fibrous cartilaginous base coming through.
So in this case, we didn't need to do anything like that. This was all just anterior synovitis. So this patient's about 6 weeks out. They're doing great. They're really pleased with it. They were virtually pain-free after about 5 days.
Wow.
So
this is the medial gutter, Dr. D. You can.
That's kind of intermedial dorsal aspect still. So this is still talus on the left, tibia on the right.
Yeah.
And
kind of make out that deltoid ligament.
Yeah, I'm trying to really see the anterior aspect of the cartilaginous surface of the talar dome, just to make sure I'm not leaving anything. So we're almost done here. We don't jack around with this too much, but look, the surfaces look good. I mean, I'm distracting now and really getting into that medial gutter.
Taking your final pictures.
Yeah, just getting some good final stills.
Look at that camera.
Yep.
So honestly, look, it took 15 minutes for Dr. D. I couldn't imagine you're doing too much more after this. Yeah, that's it.
That's pretty much it.
So recovery, what are you doing typically for recovery? Boot, brace?
I like a cam boot, a full length cam boot for about 10 days.
Yeah.
We get the stitches out and then get them right into physical therapy.
Yeah, I do the same. About 2 to 3 weeks, I'll keep them in a boot. Stitches, I'm doing 1 or 2 small stitches. I mean, honestly, sometimes I'm like, maybe I should just put a steroid strip on this because these incisions are so small. And the recovery is like this. I mean, honestly, active range of motion after surgery, I'm telling them just pump that ankle as much as you can up until, 2-3 weeks out, and then maybe some PT.
Absolutely.
Yeah.
Yeah, it's a great, I think, underutilized technique for lingering ankle pain, for sure.
Yeah. Have you seen those new in-office scopes? So,
yes, for just doing a diagnostic, quick little look.
Yeah. I think it's honestly going to be a new wave, honestly, because we're doing X-rays, we're doing ultrasounds, we're doing MRIs, CTs, etc. But to physically see what's going on the inside, a small stab incision, numb up the ankle, small stab incision, and you go in with these little plastic scopes that you can kind of sweep through, see exactly what's going on, and determine if it's just synovitis, if there's an osteochondral lesion, if there's more, whatever it might be. It's I don't know. I think it's a game changer, and hopefully FDA approves it.
Yeah, I think they could be really helpful. Yeah. You're not going to be able to do the therapeutic aspect.
No. This is just visualization. Yeah.
Get in there and take a peek.
Yeah.
Very good. Well, thank you, Dr. Hussain, for setting up the slides for our ankle arthroscopy podcast. And if you guys have any questions, if you want to hear more about ankle arthroscopy or ankle surgery, let us know, and we will fire up another episode for you. And we will see you next time on the Pod Doctors.